Good afternoon. This is Susan Shane, Medical Director here at OneCare. Thank you for joining us for this Noontime Knowledge session. Today we will be speaking or have a presenter speaking of opiate prescribing and tapering strategies. A couple of housekeeping items before we begin. On this WebEx, all of the participants will be muted during the session and then unmuted in time for the question and answers. We do have a chat box which you are welcome to use during that portion of the session as well. There is an evaluation form at the very end of this presentation, and we'd greatly appreciate any feedback you have, and if you would fill that out. This is also a WebEx that will be recorded, and it will be housed on our OneCare Vermont website for you to either listen to again in the future, or you could tell colleagues if they were interested. So our agenda today is posted on the screen. We have Dr. Charles MacLean, who will be presenting on opiates. Dr. MacLean is a professor of medicine and associate dean for primary care at the Lerner College of Medicine at UVM, where he directs the Office of Primary Care and the AHEC program. He's completed research on a variety of topics in population health and primary care, including clinical support systems for diabetes, automated screening and brief intervention for substance abuse, and the use of the EMR for population health. As an educator, he's a faculty member at the Center for Clinical and Translational Science, an academic detailer for the Vermont Academic Detailing Program, and he helps direct the UVM Project ECHO. He's currently working on projects related to opiate prescribing and primary care and in the post-operative setting. We are so pleased to have him join us today for this presentation, the objectives of which are to understand the epidemiology of opioid prescribing in primary care and the post-operative settings, and to be able to discuss the approaches to tapering chronic opioid therapy. I know he has a lot of content today to share with you, so I will now introduce Dr. Charlie MacLean.
Can I get a little feedback on whether or not people can hear me?
We can hear you. Thank you.
Great. So I'm not in control of the slides, so I'll have people step through. The first acknowledgements I have, though, are first off the Office of Primary Care, and then folks in the Vermont Academic Detailing Program, both of which I'll refer to in the presentation and have helped a lot in terms of working on these various projects. So next slide. So the outline, I'm going to speak briefly about the scope of the problem, talk about Vermont and national guidelines and rules, and then some update on work we've been doing here, and then time at the end around how to taper or consider tapering. Next slide. So I'm going to start with the take-home points. So this is kind of what I am going to cover. Opioid prescribing has actually been decreasing since 2010. That was peak opioids. Rules, regulations, and guidelines are probably helping with that, but they may actually have some unintended consequences. I think that post-op prescribing is also decreasing and is probably approaching right size. And then most opioids are prescribed in primary care, and I'll show you some data on that. And that's very complex, which I'll refer to. And then tapering chronic therapy is challenging. So next slide. It looks like there's a chat from Joe McSherry saying, is there audio? So he may need to figure that out. So opioid prescribing in the U.S., this is a chart that's familiar to many, showing an increase in opioid prescribing that basically more than tripled between 1999 and 2010 over that decade. which is the top dotted line, and then the middle line that pretty much parallels it is a tripling of opioid deaths during that roughly decade. Next slide. Two slides on downstream consequences. One is the various health concerns that have resulted from the opioid crisis that you can see there, estimated in that last bullet point to be about $73 billion annually in just the healthcare costs. And then the next slide. These are some of the downstream societal costs that we've probably all heard about. Next slide. So the CDC in 2016 came out with guidelines. They were widely publicized. There was a letter to every prescriber in the country from the Surgeon General and something from the CDC directly, laminated cards. Next slide. This is my condensed version of the 12 guidelines. So always use alternatives when possible, explain the risks and benefits, including detailed informed consent, which is required in Vermont law, focus on function instead of pain, particularly in chronic therapy, start low and go slow, and then various recommendations around how to track and be observant and thoughtful about surveillance for misuse, and then avoiding concomitant benzo use. Of interest in the small print at the bottom, in April of this year, the CDC had a press release and a advisory kind of noting that there was probably some misapplication of these guidelines with too rapid tapering, aggressive tapering, leaving patients in the lurch, and other unintended consequences. So if you're interested in kind of maybe some of these unintended consequences, I would refer you to that guideline or that press release from the CDC. Next slide. So a brief summary of the 2015-16 and then the new 2017 rules in Vermont. The early rules were pretty much a reflection of the CDC guidelines, largely focused on chronic therapy, and then the 2017 rules brought in quantity and duration limits for acute prescribing. So next slide. So this is a map of the country updated in August of 17, which just gives you a sense of the variability in rules and regulations in various states. The black, dark blue, light blue, and the other light blue, and actually the green as well, are states where the quantity duration limits are actually enacted into law, so that if you want to change the rules, you have to pass a new statute. In Vermont and other states in orange, these have been delegated, so if you read the Vermont statute, it says, the Commissioner of Health shall assemble a group of people who will help make rules and regs. So there's flexibility there. If we think the rules are not what they should be, there's an avenue to change them without having to go back to the legislature. Now I think somewhere on the range of 30 states out of 50 have some kind of quantity duration limits and rules around opioid prescribing. It definitely varies quite a bit from state to state. So next slide. So the rules around chronic therapy are listed here. Some of them are. So informed consent and agreement required, the latter updated annually, use of the VPMS or PDMP, which is Prescription Drug Monitoring Program, the generic term, office assessments reflecting function, risk for aberrant behavior, and then revisit interval of 90 days. And then not that many states have required co-prescribing of naloxone for high dose or concomitant benzo, high dose defined as greater than 90 MMEs by the CDC. Next slide. So the acute rules brought in the concept of also applying written consent and agreement, the specific quantity and dose limits, which are not hard and fast, and then the PDMP if you're giving 10 or more pills. Next slide. So if you're interested in a good summary of these rules, If you go to the Office of Primary Care, you can either Google Vermont AHEC or Vermont Office of Primary Care, or this was prepared with the Vermont Academic Detailing Program, so vtad.org. All of those will take you to a link to this summary. Next slide. So it's all of the rules, basically 2 sides of 1 page, updated earlier this year. So I have that posted on the bulletin board at my office, and I refer to it all the time. Next slide. So a little bit about the epidemiology. Next slide. So the questions that I've been trying to answer or do research around over the last several years with help from the health department, with subfunding from the CDC, have been in a wide cast of characters. Who's prescribing, what are the changes over time, and how can we do a better job? So next slide. So most opioids are prescribed in primary care, and I have here for you 2 references. One is from using IMS Health National Prescription Audit data. So this is one of those large clearinghouses of drug prescribing data. This was published in 2015 and looked at trends between 2007 and 2012, showing that about 44% of the total morphine milligram equivalents, or MMEs, are prescribed in primary care. So that would include, surgery, ER, pain clinics, etc. So primary care has almost half. And then there was a study that was done using the Ohio PDMP, so all the prescriptions actually filled in Ohio in that interval, and their combined internal medicine and family medicine were, again, about half of the opioids. Next page. So this concept of peak opioids in 2010, this is probably the best summary study I could find on this. And this looked at, again, this IMS data feed or clearinghouse between 2016, or I think it's 2006 and 2015, I apologize for that typo. So peak opioids was 782 MMEs per capita in the U.S. in 2010, decreased into 640, a decrease of about 18% during that interval. Of note is that the 2015 prescribing, even though it's down almost 20%, is still 3 times the per capita rates from 1999. So it's decreasing, but it's still a lot higher than where we were in 1999. And that map is available at the CDC, in the MMWR, and a bunch of other maps. I give that one as an example of kind of how you can look at regional variation. Next slide. So looking more locally, we have about 60,000 or so patients who receive their primary care at UVMMC, and we use that as a base to look at the next or sort of more local data. I'm currently working with the health department on trying to also use our PDMP to look in more detail around the state. But what I found is that the UVM Medical Center primary care practices are fairly representative of other primary care delivered in the state. So you can see the first 2 bars, family medicine, internal medicine, are in our world about 70% of the opioid prescribing. The anesthesia pain clinic is the only other significant player on this chart. Next slide. This is now that same exact chart, but trended between 2015 and 2018. So you can see that in both family medicine, internal medicine, the slope is downward, and it's even steeper in our pain clinic, not because they're prescribing less, but maybe because there have been some administrative and workforce changes over there. But the overall prescribing, as you can see, is going down across the board. Next slide. So looking at the total population of primary care patients, about 9% of people received an opioid anytime in 2018, and that's down from like 10.5% in 2016. So that would mean any opioid for any problem. So you went in for surgery, you broke your leg, including acute and chronic. And then of those, if it's roughly 10% of 62,000, it's 6,000 or so patients. Of those on an opioid, about a quarter are chronic, and of those total patients on an opioid, about 5% are on what are called or considered high-dose opioids, greater than 90 MMEs per day. And then I also looked at co-prescribing of GABA agonists, so benzos and zolpidem and the other drugs in that category. And of those, anybody on an opioid, about a third had any GABA use at any time during the year, so that could include just one pill of lorazepam before getting an MRI. About 20% are on at least weekly use, and about 10% are on daily use. So that's just a sense of chronic therapy and co-prescribing of benzos. Yeah, go ahead to the next slide. So I'm a big fan of using population management and peer comparison to help guide how we practice and how we find the best solutions for how to take care of patients. And so this is an example slide of a hypothetical practice, Pearl Street Internal Medicine, which doesn't exist, but it's an example of what this can look like. And what you can see here, each vertical bar represents an individual prescriber, MD or PA or NP in a practice. And what you can see on this is the changes over time, which kind of reflect the bigger picture I was showing earlier. This happens to be between 2012 and 2000. The thing that struck me when we started to look at this in more detail at the practice level is that there are three prescribers who seem to be very, very different from the rest of the prescribers in this particular location. Next slide. Here's an example of another practice showing similar changes. And what I wanted to demonstrate on this slide is the navy blue prescriber is prescribing about 1.5 million or 1.7 million MMEs per year in 2013, but drops off the radar completely in 2015. So this is an example of a prescriber who moved out of state. And obviously the lavender prescriber overlapped a little bit in 2014 and then took over that practice. And the drop in prescribing between 15 and 16, I have the data for the subsequent years, it continued to go down. And when I interviewed the folks in practice and discussed things with them, it became quite clear that the lavender prescriber was someone who took a very different approach than the navy blue prescriber and was probably more in tune with recent guidelines. And it was also during the era when I think there was a lot more scrutiny. But the point is that the approach of the individual prescriber can make a huge difference. Next slide. So we've been working mostly Connie Van Eegen and not Mark Levine, but Mark Passanen over the last few years on technical assistance work with a variety of primary care practices using QI methods. Next slide. And the rationale behind this was obviously, public health concerns, changing standards of care. Our first foray into this in 2012 was around a lot of the kind of disruption and splitting and confusion around prescribing, like when meds are due and that kind of stuff that can be pretty disruptive to the front desk. And this idea that prescribers needed maybe less education and more help just with implementing these kinds of things. So Dr. Van Egan is a QI facilitator, and she helped work directly with practices figuring out how to solve the problems that were bothering them the most. And thanks to VDH for helping fund this over these years. Next slide.
Dr. MacLean, we're interrupting you just for a second. I think there's one individual who's not muted. If Laura could actually mute her computer, we're getting a lot of feedback, and I think it's coming from that source. Thanks.
Okay, next slide, please. So we've developed what we have over the course of these years working on this project, what we call our opioid implementation toolkit. It's in its second to third iteration, and it's kind of a guide to what are some of the strategies. So the early strategies we had a series of 14 of them. Many of those are now required by law. There were things like using a consent form and using VPMS and prescribing for chronic patients in increments of 7 so that prescriptions are never due on the weekend, simple things like that. Most practices we're working with now have really adopted all of those. So we're sort of into kind of the next level of this. And I would say that most of this is focused on chronic, not acute prescribing, because that's where the, Sutton's Law tells us that's where to go. So the various more advanced primary care strategies that we've focused on for maybe your most difficult or challenging cases are listed here, and I'm going to spend a second on these. So if you're frustrated in primary care and you can't figure something out, often referral to a specialist is extremely helpful. If you look around the state and around the country, the availability of comprehensive pain clinics as opposed to maybe an interventional type of pain clinic, they're really not that available, and it's one of those situations where I don't think we're ever going to have enough access to comprehensive pain clinics to meet the need. So that's an option, but it's potentially not going to be available to enough people. The concept of peer consultation is, I'm frustrated with a situation with a patient. I'm not sure what to do. Can I refer to one of my peers right here in the office for an in-house second opinion? So that's something a few people have been starting to work on, may be helpful in certain situations. The concept we're working with mostly right now is the concept of an in-practice opioid council. So that's the idea that we work together as a practice, we cover for one another, we're prescribing dangerous substances. So for cases who are in that category, decisions are kind of shared across a group. So the challenging cases are brought to a subgroup of the practice that might include, physicians, NPs, PAs, and maybe a nurse or a case manager. And the case is presented, discussed, and kind of group recommendations are made. It's sort of on the model of a tumor board or that kind of group approach to shared decision-making across a variety of professionals. Fairly easy to implement, and we've got some ground rules on how to help make that happen and experience doing it with a variety of organizations. Then the other concept that I think we don't have that is sort of on my wish list, for those of you who do medication-assisted therapy or MAT, that's office-based opioid therapy with buprenorphine for drug addiction. That type of team-based approach typically includes a licensed alcohol drug counselor, a case manager nurse, and a Suboxone prescriber. Having that team approach with different folks having different designated roles and supporting patients on the phone in between visits really helps make that work, and I would love to see that kind of approach implemented for patients with living with chronic pain and on chronic opioid therapy. When I've polled various audiences of which of these strategies would you most like to see, that last concept is very appealing to primary care. Next slide. If you're interested in the toolkits, again, if you go to the UVM AHEC program, if you just Google that, UVM AHEC, it will take you to this website under the resources for professionals, and the toolkits are available free of charge or open access. So my summary of kind of the status in primary care right now is that there's wide variability in prescribing within practices. I didn't talk about this much, but there's a lot of patient factors, age, comorbidities, tolerance. There's a lot of prescriber factors, which, one of the important predictors is how long you've been in practice, the type of practice setting you're in, your schedule, your style. And one of the things I hear, particularly from a lot of NPs and PAs who might be taking over from a retiring physician who's been in practice a long period of time, is this concept of inheriting a legacy practice is a big deal in terms of, inheriting a group of patients where your approach might differ from the person you're replacing. So if you apply the math of the earlier slide I showed you, if you had 1,000 patients in your panel, you might have 90 patients who got an opioid last year. You might have somewhere between 5 and 20 chronic patients, and you might be prescribing somewhere on the order of, between 25,000 and 1.6 million is sort of the interquartile range for the amount of MMEs prescribed in a typical primary care. And I believe that benchmarking, empiric comparison, and getting together on this is a very useful way to plot our way forward. Next line, or next slide. I feel like I'm dictating. So post-operative prescribing, this is a list of people who collaborated on this, and I'm going to summarize briefly what we did in this project. We called patients at home a week after common operation, asked them how much of the prescribed opioid they actually used. It turned out to be about 30% of what was prescribed. That information was fed back to the surgeons, and that was sort of coincident with the new 2017 acute prescribing rules coming online. And then we looked at prescribing before and after that change. So the next slide, you can skip next. So this is, I included all those for your reference, but they're descriptions of what I just summarized. So what this shows you is a smooth curve of the change in median morphine equivalents prescribed at the time of discharge to patients with a wide variety of surgeries in general surgery, OBGYN, and orthopedics primarily. And what you can see is the first box is kind of the baseline period. The middle box is during 2017 while we were feeding back information from that study and the rules were being applied. They kicked into place in 2017, week 27, which is where that second vertical bar is. And there's two things you can see. One is that the amount of MME prescribed decreased fairly precipitously across that adoption phase. But the other thing I would point out is that the amount of variability around that line tightened up a lot. So it's an idea that, yeah, people are now more on the same page, more following a standard, tighter distribution around that, and about 18% or 40% drop in amount prescribed. And so the reference is there. Next slide. Next slide. Next slide. We put together a couple of one-pagers that also have accompanying videos that also are available on our AAC website. One on the left is directed at patients, how to take your meds safely after an operation, and how to dispose of the leftover. And then on the right, it's a summary set of bullets targeted at postoperative surgical prescribers, which might include around here attendings, residents, NPs, and PAs. So those are available on our website. Next line, or next slide. So now let's talk a little bit about tapering. Next slide. So when to consider tapering meds. One of the key points that's made in the, I think, the CDC recommendations and some stuff from the VA that I'll share with you in a minute is that particularly when embarking on treatment for a chronic condition, thinking about an exit strategy at the time you initiate prescribing is probably one of the most important concepts to understand. And that's the idea that, if I'm having a conversation with a patient and they have chronic back pain, which is probably the most common reason that people are treated with chronic opioid therapy, you can discuss the risks and benefits and you come to this decision that we're going to try it. The idea that, okay, if this works, great, but if this doesn't work and we find ourselves 1 month, 2 months, 3 months, 4 months, whatever from now, and it's really not helping in terms of pain and function, then we're going to taper it. It's like any other treatment. If I try a blood pressure medicine and it's not working, we're going to try something else. So having that conversation up front very explicitly, I think, is critical. The other time to consider tapering is when you really come to that place where you can logically state that the risks are now outweighing any potential benefits. And some of those reasons might be the things listed here: lack of effect, side effects, comorbid risk factors are making it riskier than it was maybe 5 years or 10 years ago for you. When you're on a particularly high dose, because we know that the inadvertent overdose and problems, really are much increased. That curve really bends steeply at about 90 MMEs. When you're on a concomitant benzo, and when there's high-risk behavior such as, addiction, misuse, and diversion, and issues like that. Next slide. So I'm going to share with you 2 studies from the last couple of years that are kind of FYI. This first one by Busey et al. From 2018 in JAMA was a systematic review and meta-analysis of do opioids help for chronic non-cancer pain. And their findings are listed here. They include 96 randomized controlled trials, almost 30,000 patients. And while the use of opioids compared to placebo was associated with less pain, so they were effective at decreasing pain and improving function, the magnitude of the association was relatively small. So the meaning they took away from that was that opioids may provide benefit for chronic non-cancer pain, but the magnitude is likely to be small. So I think that's really important to understand that, there's a lot of negative talk about opioids these days that relate to misuse and the opioid epidemic, et cetera. And we have to keep in mind that for some patients, these may be very effective medications. We have to keep it in mind. Next slide. This is the SPACE trial, which has a great acronym. This was an actual randomized controlled trial of patients in the VA, set up as a pragmatic trial over 12 months, which is a real virtue in studies of chronic pain, because a lot of the literature on chronic pain, I if you could see me, I would be putting chronic in air quotes. It is, many of the studies are 3 months long or 6 weeks long. They're really short duration. They're not really chronic pain. So this had the virtue of being a 12-month trial. And they really randomized people to opioids in a stepwise fashion. They had an algorithm, start here, go there, keep increasing it, and then a non-opioid category. And their conclusion was that, and these were all people with chronic back pain and osteoarthritis type of pain. So probably quite representative of the types of patients that we see, though they were all veterans. So their conclusions and relevance are pulled out there on the right. Treatment with opioids was not superior to treatment with non-opioid medications for improving pain-related function over 12 months. Results do not support initiation of opioid therapy for moderate to severe chronic back pain or hip or knee osteoarthritis pain. So I would invite you to, read that trial in more detail if you want to learn more. Next slide. So here's a couple of slides on what's the evidence around tapering. So there was a Cochrane review done in 2017, and the subnote there says conclusions are limited by lack of well-designed definitive studies. So there really isn't a lot of great evidence on what works and what doesn't. I think we're actually very early days on this whole new world of trying to find our way to what the so-called right amount of prescribing really is. And the quote from their conclusions, the findings to date are mixed, reductions in opioid consumption after intervention, decrease in the intervention groups, but often in the control groups too. And that's probably the effect of, being in a study and having attention around your pain and function probably help to mitigate it. Next slide. Next slide. So there's two resources that I would recommend if you're interested in learning more about tapering, both from the VA. The one on the left is probably a 20-page or 30-page booklet that talks about the evidence base around some of the other therapies for chronic pain. So, and gets into some info on tapering and how to manage withdrawal. The booklet on the right is a little shorter and to the point. It's more directed specifically around tapering itself. So next slide. So those are available if you just Google, the title and the VA. It'll easy to find, available in a PDF. So in the academic detailing program, Rich Pinckney has helped out a lot with this idea of compassionate tapering and thinking about tapering in sort of 4 categories. There are, the two on the first one and the fourth one are probably kind of the easier of the 4 categories. So if a patient comes in and says, I've been on these meds, I'd really like to be on less and see what that feels like, see if I can get off these meds, then, it's a collaborative approach and coming up with a schedule and timeline that kind of makes sense based on their condition, availing yourself of what other therapies might be, brought to bear. The fourth category is when someone has truly aberrant behavior. So if someone is selling half their meds on the street, or they are found to have, they're not using their meds at all, despite your contract maybe saying that they are using them, then that's fairly straightforward most of the time, not necessarily pleasant, but at least straightforward. I think what's a little more challenging is the two in the middle, where, if you as the prescriber, so for an involuntary taper, say, that might be a scenario where, you know, you have a patient who's maybe on a very high dose with a concomitant benzo. Maybe you feel like there's some side effects that the patient maybe in a little bit of disagreement about, like over-sedation or confusion, and your best advice is that this person should be on less medication. They're not necessarily volunteering for that, then I think that's more of application of motivational interviewing and exploring and figuring out ways to improve pain and function, bringing other therapies, and really moving somebody along. You know, that's where a comprehensive pain clinic can be very helpful to, you know, find a solution for a patient like that. And then the possibly aberrant is one where you're kind of maybe suspicious about the fourth category, but it's not clear. And I think in my experience, those situations, they don't come up often, at least for me, but they can be particularly challenging. Next slide. Next slide. Go back up one maybe. So this here is I'm not going to go through this in detail, but it has some examples of sort of those voluntary, involuntary, hazy, and then clearly aberrant with goals and strategies. Next slide. So the VA, you know, to summarize in 3 bullets or 4, what the opioid tapering recommendations from the VA are is to reduce by somewhere between 5 and 20% per month, with note that some people may require a very slow taper of maybe 2% a month. It's appropriate to consider pausing at different times during a tapering process while people are adjusting. And then they really do emphasize the helpfulness of a team-based approach with mental health support. Next slide. So if you're interested in up your game around opioid prescribing and tapering, I would offer you these suggestions. Number 1, read the VA materials and maybe get together with your colleagues in your practice, read them together and discuss them, and really try to have some good conversation around them. I think meeting with your colleagues to develop a common practice strategy is very helpful, and our opioid toolkit can maybe help you figure that out. We have, with support from the health department and CDC, trained, Connie has trained all of the blueprint facilitators in the state who support primary care, so they should be able to help your practice use QI approaches to implementing some or all of the aspects of that toolkit. I would say sign up for one of our academic detailing sessions. The one on advanced opioids covers some of what I've been talking about in more detail, including the tapering strategies. Those sessions are designed to be kind of in your practice with multiple prescribers around the table to kind of have some good give and take and discussion. So it's kind of like a guided number 2 sort of meeting with your colleagues to develop a practice strategy. You can contact our Office of Primary Care. We are hoping to have funding in the next year, depending on the CDC, to offer technical assistance to some other practices, particularly those who are identified as really having a high need. So you can be in touch with us on that. And then lastly, we've been running a Project ECHO. For those of you not familiar with that, it's web-based learning collaborative, essentially, that focuses on assembling a cohort of people that meet by video conference roughly every 2 to 4 weeks and actually present really tough cases. So we're running our second ECHO right now on opioid prescribing. We have an ECHO on Lyme disease, and we have an ECHO active right now on transgender care. So we're hoping to offer another echo in the future on opioid prescribing. And the virtue of that is really it's very engaging, and you really get to present your own cases and have a group of very interested individuals help try to solve the questions that you're facing. Next slide. So other acknowledgements of folks from the Medical Center and College of Medicine, folks from the VDH back as far as Harry Chen, a variety of practices we've worked with in medicine and dentistry, and then folks at the Blueprint. Next slide. Some resources, including our website at the Office of Primary Care at the bottom. And then next slide. Questions. So I'm not sure how you guys want to do this. Certainly you can chat in a question, or I guess people can unmute or raise their hand.
Can you let me see? So Dr. MacLean, thank you very much. This is Susan Shane at OneCare again. Because we have over 100 people on the phone, we are just going to ask them to use the chat box. And if you...
I can see the chat box, so I can read the question and answer them.
That would be
great.
great.
Have a note from John King that he was enthusiastic about the Opioid Council and team-based approach.
Charlie? Just
yes.
If I might just, while we still have people here, just to say, yes, they'll use the chat box, otherwise they're muted. And just to remind them at the end, there's an evaluation we'd love them to fill out for us, and that this is, will be accredited for 1 hour of CME, but the UR code will be sent to everyone who signed up for this, as it has not yet been sent to us by the UVM CME office.
Okay, and if you want to go to the next slide or two, I think you had a couple on how to claim credit or, yeah, there we go.
Sure, so that'll be, I think Tanya has sent the PDF to everyone, and this would be in the back, or if you look at this, certainly they can contact us with any questions.
Okay. And if people want to use the chat function, if you just mouse down to the bottom of the page in the middle, there's a little call-out symbol that will open it up in a sidebar for you to type a question. Great.
How about taking that first question?
The first question was, is there audio?
Okay. How about the second question?
We have a question here from Sullivan Anthony Zariello to everyone, who says, do you know of any resources or guidance on tapering MAT patients, that is, reasons to taper other than criminal activity? So I am a MAT prescriber. I don't have a huge panel, and I don't have long experience with that, so I'm probably not the best person to answer that question. I would probably recommend someone such as John Brooklyn or Mac Abernathy or Sanchit Maruti. Those are 3 people at the on the faculty at UVM who are very experienced with MAT over many years. Norm, that's a question. What % taper might theoretically result in any withdrawal symptoms? So I think that's very individually dependent. But I think something more than 10% per week would probably result or could result in some withdrawal symptoms.
Charlie, I would just like to add to this at OneCare that if there's interest, we're just laughing because this muting, unmuting is getting confusing. But if there's interest, it may be that we could have another Noontime session where we have someone come and talk about the tapering in more detail.
Yeah, that'd be possible. Any other questions? Please use that chat box and, oh,
Wonderful.
So, question from Nathaniel Burns. You mentioned similarities between pain committees and MAT committees, but one difference is that at my MAT committee, we discuss every single patient, but the pain committee at my clinic only discusses cases submitted. Therefore, there may be many patients who are prescribed very high MME and never get addressed in committee. Providers may not want to submit cases because they feel embarrassed. So this is a fabulous question because I think, Mark and I have both, Mark Passon and I have both been in practice for a long time, and we both have had situations that we're very happy to admit, are patients we've probably overprescribed for. And one virtue of taking a population based approach is that, if we're looking at, okay, who in our practice has poorly controlled diabetes? We look at the entire roster. And, yes, there are people with diabetes who always have an A1C of 14. And the reason they have an A1C of 14 is often extremely complex. It has to do with the patient. It has to do with their home circumstances. It probably has to do with their, ACE score. And it might have to do with, my prescribing strategy or approach to them. So it's complicated, and it's not one thing. My experience, and the research will bear this out, is that a significant portion of folks on chronic opioid therapy have concomitant complexities in their lives that may be social complexity, or it might be mental health conditions. And, it's not an easy solution. And I think getting away from kind of a blame-based kind of approach, like, a prescriber is a, quote, bad prescriber, as opposed to a patient who is compassionate and willing to take care of very complex people with coexistent physical and mental health and social problems. That's kind of where the practice has to really embrace this. So, over the course of the last several, probably 5 years, we've taken this population-based approach within our EMR and actually created rosters similar to here's your panel of patients with diabetes. We have a roster baked into the EMR now that has, here's all the folks you prescribe for, and here's who's on a concomitant benzo, and, here's how many prescriptions they got last year. And it's, we all sit around and talk about it. So I think that's where, one of the suggestions I had, if you want to, quote, up your game, was the idea of getting together with your colleagues to say, okay, how do we want to approach this? And I think taking a comprehensive view that's, minimizes the blame-shame game, I think is the way to go. But thank you for that question.
Charlie, I see that there was a question right above that. Are you seeing that about studies measuring pain scales?
Okay, no, I didn't see that one. Are there any studies that measured pain scales or patient acceptance of tapering? What is considered successful? That is, what level of MME? So thanks, Nancy, for that question. I'm not sure there's any universal definition of successful. There are quite a few studies that have measured both pain and function and have looked at patient acceptance. Most of the ones that have looked at patient acceptance are relatively small, but one that I just reviewed, I don't have the exact reference off the top of my head, but I could find it, was one where patients who had tapered their meds or who had embarked on a taper were interviewed, after months and months and months. Some people had been successful at decreasing their dose and some people had not. And what was interesting is that the folks who had decreased their dose had equal pain control, but actually had improved function. And to me, the way this has played out in my own personal practice, so this is sort of the anecdotal equivalent of that, is patients. I inherited a patient recently who was on relatively high dose for a long time. And I said, the data are changing. Maybe we should think about a taper. We went back and forth. We agreed to try. He tapered down, and he was very skeptical going in, but, was willing to give it a try. Very articulate, knowledgeable individual. And he tapered down by something like about a third. And he said, I actually feel a little sharper and a little better energy. I'm kind of a little more with it. And I didn't realize exactly how I was feeling until I had made this change. And his pain was, maybe a little worse, but it was very tolerable, similar to what it was before. So I think it's this idea of, a lot of people don't realize maybe what some of the negative effects are until they've actually tried the taper. So I think you have to just measure pain and function the same way you normally would when you're following a patient long-term with a scale like the PEG scale, for example, is a commonly used one, stands for PEG, and really just feed that back to the patient and have an ongoing conversation. My approach in terms of success has been I'm trying to look at my highest risk individuals. So those are folks on 90 MME or greater and folks on a concomitant benzo. Okay, then maybe this question's from Norm. What % of chronic opioid users are found to have not been tried and failed on a full range of non-opioid regimens? That's also a great question. I think the evidence base around what works, particularly for chronic back pain, is constantly being updated. There's 3 randomized controlled trials of yoga that compared to other strategies that have been shown to be successful. There's a whole range of other studies of a variety of non-pharmacologic and a whole range of pharmacologic approaches. So I would say that many, many patients have not tried the full range, and sometimes it's because it hasn't been suggested, sometimes it's because they're reluctant, sometimes it's because it's too expensive, sometimes it's because their insurance won't pay for it, sometimes it's because it's not available in their community. So there's a lot of barriers to getting people to all of the available therapies that might help them.
Great. I see that we have about 3 minutes left. If there's any other questions, please use that chat box. But let me take the time to say thank you very much to Charlie MacLean for putting this together for us. There's clearly a large, great interest in the state, as we had over 100 participants. Once again, this has been recorded and will be up on our website, and you will be receiving an email about how to access CME and CEUs. If there are no other questions, please accept our great thanks, Charlie, and keep up the good work.
Okay, thanks everybody.
Bye now.
Bye-bye.